Hi, I'm Dr. Gerald Deas. Welcome to Health Center from Downstate Medical Center. Today we're going to hopefully help you out there who might be experiencing pain. Now I'm not talking about pain that will be resolved with a pill or an aspirin or something to take the pain away and things like this. I'm talking about pain that you have all the time. Pain that might be in your joints, pain that might be just in eating, pain that might be involved in not being able to get out of the chair. You might be in a wheelchair and can't get out of the chair, but it's possible for you to get out of the chair if somebody would help you with the chronic pain that you might have or the chronic condition that you might have. So we have Dr. Sadowski here, who's a pain management doctor from family practice, and not only a pain management, but a chronic pain purveyor who can really give us some help if you're sitting out there today and you have chronic conditions that you want to improve. And I want to welcome you, Dr. Sadowski.
Thank you.
Yes. Dr. Sadowski, pain. Now, I don't know if you see many patients with chronic pain, and I guess you do. How do you start managing these people to accept their condition of pain? And pain, it's really interesting because so many times I had very severe pain on a train one time coming from South Carolina, and I decided to take the train, and I got a pain in my back that was so I didn't know how I was going to make it to Pennsylvania Station, and I had to do everything, and I finally had to talk to myself. And as I start talking to myself, what is pain? It starts subsiding, and I made it through. But I'm just saying how I had to control it. I had no pills, nothing to take the pain away, but I had to go into the mind for pain.
Right. Well, one of the things you did during that particular instance is you diverted your thoughts from the pain to something else.
Surely.
In other words, you didn't let the pain overwhelm your brain.
That's right.
But you sort of focused someplace else.
Surely.
But many of our patients have chronic conditions.
Oh, yes.
And those of us who've been practicing medicine for 40 years now, who have a lot of patients who are over age 50 or 60 or even younger patients, have chronic conditions that are causing pain.
Oh, yes.
And pain can be very unpleasant to the individual who's having it.
Oh, surely.
So there are several recommendations that we can make, and we can start out by trying to get to the bottom of what is causing your pain and what type of pain you're having. We as physicians have different ways of classifying pain. There's different types of pain. Pain that's generated by something that's occurring right at the site of the pain, something that may be occurring more distantly. It may be some noxious stimuli that occurs in the environment, that's actually causing your pain. So even though you may say, well, I'm having pain, it's up to us to try and figure out where that pain is coming from, what the triggers are, what makes it worse, what makes it better, and how to try and prevent this from happening in the future.
And some folks use pain to get folks around them to become more engaged with them.
Well, I think there's a
chronic condition. So the chronic condition can exist. In fact, they won't even take their medicine that might even relieve some of this kind of chronic pain or chronic condition, just because they want that person to be controlled. They want to control their surroundings.
Well, those are individuals who are looking for sympathy.
Oh, yes.
And they control their surroundings by looking for sympathy.
Oh, surely.
As you know, there's this Queen Victoria complex, which doesn't have to do with pain, but it was the fact that Queen Victoria used to travel around in a wheelchair, even though she really didn't totally need it. And by using the wheelchair, she got people to lean over a little more closely, people to bow down a little bit lower. And she used the wheelchair to kind of control the world. So we call it a Queen Victoria complex when somebody uses an ailment or a disability for control purposes. But most of our patients with pain aren't trying to control anybody. They're just trying to control their own pain and the difficulty it's causing for them.
I looked at years ago, Winston Churchill. He used to be sitting in a chair like that type of thing, or even the other, President Roosevelt. with infantile paralysis, a chronic condition. But people pay more attention to him when they saw him get up with braces and walk or get into the pool, things
Sure.
like that, you know.
Well, sometimes I think, though, that when you come into the doctor's office with pain, just the opposite might occur.
Yeah.
The doctor may kind of move away from you
Mm-hmm.
because most doctors don't want to deal with chronic conditions or chronic pain
Right.
because often they're very difficult to resolve.
Surely.
And I think a lot of doctors may initially think that people are just chronic complainers.
Oh, yeah,
As a
sure.
matter of fact, doctors often suffer from what we call clinical inertia.
Mm-hmm.
Clinical inertia is a phrase to describe the fact that when the patient keeps coming back to you with the same problem,
Right, sure.
the same problem, you kind of figure out in your mind, well, I'm not going to be able to solve this,
Right.
so I'm not even going to approach it.
Right.
I'm not going to deal with it. I'm
Surely.
going to say to the patient, well, I understand you have pain. You have to learn how to live with it.
Mm-hmm.
And that's not the right approach.
No, of course not.
So one of the ways patients can combat that kind of approach
Mm-hmm.
is when you come in and you talk to the doctor, you have to repeatedly try and impact the clinician or the doctor about how the pain is impacting on your life,
Surely.
how it's affecting you,
Surely.
how it's keeping you from eating, how it's keeping you from being happy, how it causes you to cry,
That's right,
how
surely.
it keeps you from moving around, and how it makes you feel sicker and even depressed.
Surely. And you know, a doctor has to have a sense of humor too. Because I use a lot of humor in my office. I used to control my waiting room with music, with Langston Hughes poetry, with Langston Hughes reciting his own poetry, all kinds of not hymns so much, but spiritual music that they are familiar with in their churches and things like this. Jazz, good jazz, where folks out there. In fact, they would come into me, they said, what's that last record you played, Dr. Deas? What's that last? Because I used to be my own disc jockey in the office, that I would feed this into them, you know. And it was really, and then I would have places where they could get a cup of coffee or tea, a little machine type of thing, and they would have tea. It was a cold winter day. Sometimes my wife would come home and she would cook some chicken soup for dinner, and I'd bring down some soup and ask anybody who would like a cup of soup, you know, because I practice out of my home, you know, and that comfort zone of taking that hot cup in your hand start relieving some of this arthritic pain.
Right. Well,
you
you're
know?
actually also talking about one of the biggest aspects of meditation,
Oh,
and it's
yeah.
the value of meditation. The idea is to try and divert the mind
Sure.
from the noxious stimuli or the pain
That's
you know,
right.
that's occurring at that particular time.
Oh, yes.
Now, of course, it's easier for some individuals to do that,
Yeah.
and harder for others.
Surely.
But I think we all can be taught to do that.
Surely.
That's one of the aspects of biofeedback,
Oh, yeah, sure.
where we actually try and control, you know, our emotions and
Of
some of
course.
our physiologic activities that are
Surely.
occurring.
Surely.
But let's look at something like meditation, which I often tell my patients about. Not meditation in quotation marks, but I try and talk to them about ways that they can diminish pain or they can diminish unhappiness and upset.
Oh, yes.
And that is not to concentrate on it and try and think about something else.
Right.
For example, one technique would be visualization.
Tremendous.
Pain comes on,
important, yeah.
or some kind of other upset comes
Mm-hmm.
on, but you can try and visualize yourself at a beach or a happy scene or a family scene from your past.
Yeah, surely.
And by doing that, you can sort of replace the painful stimulus with something that's a little nicer and makes you feel more comfortable.
Well, you know,
And that's really what meditation is.
well, you know, Aldous Huxley showed that. Aldous Huxley, a great philosopher, used to meditate in stained glass windows. That is, he found that when you meditated for a period of time, and over a period of time, you lack certain kind of vitamins and things in your body that start giving you hallucinations. The hallucinations came in the form of geometrical colors. So he showed how the monks, when they made those glass windows with those geometrical colors, how instead of fasting so much, if they concentrated on those geometrical glass colors in that window or pane as such, that they could be relieved of pain and other things also, because everything started associating with the visual to the nervous system, and then bringing in another aspect of God, all powerful, that controls, say, emotions or pain and things like this. And so Aldous Huxley played a major role in showing people how you can control chronic pain by just meditating, what you just said, but you don't have to say get off, have a diet, no diet or anything like that. If you could just visualize something that would give you that feeling that you could relieve the pain.
Right. It sounds like you're talking about something like mind control.
Mind control.
And to many of your viewers, that may sound really far out.
Yeah.
But actually, there are all different aspects and
Surely.
all different degrees of mind control you can do.
Oh, yes.
And I bet most of your viewers, if not all, could sometimes control some of these unpleasant emotions that are going on in their head
yes.
by trying to divert their thoughts from something unpleasant to something pleasant.
Yes.
And we talk about that in my office as one way of treating pain. Now, many people don't really know who to go to,
Right.
when they're having pain.
Right.
And the first person certainly to approach is your primary care doctor.
Oh, yeah,
I
sure.
mean, that's the first person. And very often your primary care doctor can manage the pain, either by resolving the problem
Sure.
or by masking the pain with some kind of pain medication,
Oh, yeah, sure.
or by teaching you these kinds of meditation or mind control activities
Sure.
that help you deal with chronic pain a little bit better.
Sure.
There are also doctors who specialize in pain management,
Yeah, sure.
and they're called pain specialists. And there are a number of them here in Brooklyn, and they're very useful, patients who have chronic pain that hasn't been relieved by any of these other techniques.
Right, sure.
It generally requires a referral from your primary care clinician to the pain management specialist. But pain management specialists can be very helpful. But I have found that very often they have a very clinical perspective. They don't delve into what's going on in your life that might be impacting on
Surely.
your sensation of pain.
Surely.
Because you know, Dr. Deas, that some people can have pain and resist it and live a normal life. Other people can have that same degree of pain and they're flat in a bed.
That's right. Oh, yes.
So the way people respond to pain is very different.
Surely.
And that's a conversation that's best had with your primary care clinician.
Well, last night, my son put on the internet and he showed some of the old Bill Cosby shows, and this one of this daughter coming home from college telling her parents that she's not going to go back to college because she feels another urge to do something else, and the reaction that the parents had, it almost sounds like my child telling me something like this. So, and they had a son. Oh, she got married to a guy that they said, well, what would you like? What do you want to do? He said, I want to open a store selling tents and camping goods, things like this. And they were going all to pieces, the parents, thinking these two people are going to upset their lives by not following what they suggested you should do in life. One was going to Yale, one was going to Harvard,
Right.
But they were going to deviate, and all of a sudden they had pain.
Well, I think that there's all different kinds of definition of pain. And hopefully that pain can be gotten over by some conversation, even though it may take some time.
Yes,
and
right.
the resolution of pain can take time.
Oh, yes.
And we need to remind people that very often doctors don't have
Right.
a quick fix.
Yeah, sure.
It depends on what's causing the pain, how you're receiving the pain, what kind of gains you might be getting from the pain.
Oh, boy.
As we spoke about
Big
earlier in the
gains.
show.
Sure.
So pain isn't necessarily something that one doctor visit can resolve. I can't tell you how many patients have come to me who have said to me they've gone to another doctor for their pain. Doctor gave them a pill. It didn't work. So they're not going to go back to that doctor anymore.
Sure.
And I have to try and explain to them that the resolution of pain and the management of pain is a continuum process.
It is.
In other words, you go to a doctor. Doctor starts with a first line
Sure.
evaluation and management plan.
Sure.
If that doesn't work, then you go back to the doctor and you go on to the second line.
Right.
Sometimes if you doctor hop, you're going to stay at that first line all the time
Sure.
and you'll never get beyond it.
Sure.
So don't do that. Try and find a doctor that you trust
Surely.
Somebody who listens to you
Of
and
course.
empathizes with you.
Well, you know, there was a Life magazine article years ago where people had knee pain. And usually when you have very severe knee pain, sometimes it can be a defect in the cartilage there, the meniscus, that can give you severe pain. Well, they set up an experiment where people who came in with knee pain that from the x-rays and things, didn't really look like it was that much pain. They made an incision, but they didn't put any instrument into the joint. Mm-hmm. They just sewed up the incision. Mm-hmm. Well, the patient came out of the surgery. I feel much better. Oh, much better.
Right.
You know,
well, we call that a sham operation.
Yeah, right.
And,
but let me say this: they wanted to show a lot of this knee pain is related to your interpretation of this bad knee with something in there, like a torn meniscus and things like that. But at the same time, they recuperated as fast as a person they did the operation on another person.
And that's a very important concept in a lot of different kinds of pain.
Sure.
But you know, our patients who are unfortunate enough to have, you know, metastatic breast cancer to the bone, they really have pain.
Oh, yes, surely.
And that pain needs to be treated. And we really need to try and work on that. And, you know, doctors are very nervous about giving out what we consider to be the optimal pain medication known as narcotics.
All right, of course. In fact, when that came into being, because a lot of these narcotics have become narcotic mills. Some doctors will just give the patient pain pills, where they had to pass a law. And in my time, where if you wrote anything such as a very thing like morphine or something like that, we had a triplicate prescription. Right. When we wrote it, we kept a copy in the book. The druggist got a copy, but then one copy was sent to Albany. At that point, it really knocked out the mills. Now, these companies who were selling pain medication got very angry at that thing because it now was controlling. You couldn't have a mill where you're writing prescriptions all day for pain. And doctors get into that, writing prescriptions all day for pain. Oh, you go to Dr. So-and-so, he'll give you something for pain. You know what I mean? And it is morphine. It is one of these terrible addictive drugs and things like this. And it was going crazy. Right now, we've had this in our society right now where doctors are just writing prescriptions for pain. How could you write prescriptions all day long for pain and nobody checks on you? So the triplicate through one of the legislative things, they discontinued it because of the pressure that they were getting, and now it's coming back because they said it's the only way we can control doctors that have pill mills.
Right, I think that's true, and I think we have to be careful about that. We also have to be careful about doctors who are too reticent or too hesitant to give appropriate or adequate pain medication in addition, because a lot of doctors, very legitimate and capable doctors, don't want to give their patients narcotics because they're afraid of the state looking at them as being one of those mills that you've just talked about.
Of course.
So it's very important that patients be honest and sincere about their pain. And talk about their pain and try and find out from their clinician what would be the best thing to do.
Well, you know, I never hesitated in giving a pain medication like morphine or something like that. If I went on a house call, for example, and a patient couldn't get out of the bed because of severe muscle spasm, terrible pain, and there can be no worse pain than when that pain hits you in the back and you can't get out of bed. And this is a reliable type of patient. I wouldn't hesitate to write a narcotic prescription for that patient, and they'd be out of that bed in 2 days to get up and get around, and they did much better because you had to interfere with the pain.
Right. Well, most doctors would agree with that. When we're talking about chronic pain, then you become administering the medications for a long period of time. Doctors can still do that.
Right.
I think that we can do that as long as every several months we sort of reevaluate what we're doing.
Oh, surely.
How is it relieving the pain? Is there some other way to relieve the pain?
Surely.
Are there psychologic issues that are involved?
Surely.
Should we continue to prescribe the narcotic?
Right.
So I think the safe way for doctors to do this is to reevaluate the situation every 3 to 6 months and try and see if the patient really needs. The patient who has metastatic breast cancer, they deserve and may need narcotics for the rest of their
Well,
lives.
the sickle cell patients, I think the greatest pain I have ever treated was crisis, sickle cell crisis or sickle cell pain. That is one of the most, patients have told me that they feel like they could leave the world because of the pain. And so I had to use narcotics. Then people started looking at these patients coming in the emergency room with sickle cell patients, and they started saying, oh, they're addicted, and wouldn't give them, know what they give them? Saline,
Right.
which is the worst thing. That patient would lay there for days in that emergency room with saline being, thinking that they were doing psychologically something with the patient, that they were, it's cruel, plain cruel. They needed something to stop the pain. When you have a heart attack, for example, morphine, if that pain is severe in your chest, you better get morphine, because you got to put that patient down to start bringing in their own cells to...
Of course, because pain can cause a rise in blood pressure.
Of course.
It can cause the heart to beat faster,
Surely.
to demand more blood. So pain itself is a noxious and not only unpleasant, but potentially damaging symptom.
Oh, it is.
So it's very important to cut it
to make
back.
that patient, even after a heart attack, and if you haven't had a heart attack, you don't know what that pain must be like. You know what I mean? And they're laying in bed, and they give them some kind of sedative or something like that. You got to get rid of the pain.
Right, and what you just mentioned about not knowing what the pain is like. You know, many doctors, many are younger.
Sure.
Many of them have easy access to pain medication and pain management when they need it themselves.
Sure.
So they tend to discount the impact that pain can have on somebody's life.
Oh, yes.
And they tend to think that all pains can be resolved by a couple of over-the-counter tablets.
Surely.
So again, I think it's important that people go in and talk to their doctors about the pain that they're having and be somewhat insistent that the pain get resolved, and that the doctor sort of measure their pain in some objective manner, perhaps on a scale of 1 to 10. Go in and tell your doctor, this pain I'm having is a 10.
That's right.
Or if the doctor's tried to manage it with some treatment, you can say, well, your treatment has gotten it down to an 8.
Right, surely.
But I would like to get it down to a 2.
That's right, surely.
So you've got to keep helping me to reduce the level of pain that I have.
Well, that's why I think marijuana is even coming into play here now, reducing some of this pain as such. People say, oh, well, you'll get addicted. You know what I found out about people who really have pain? They don't become addicted. What I found in sickle cell patients particularly, when their pain was relieved, they were fine. And if you said, you want some more? I don't need any more. I don't want to be an addict or anything. But they're perceived as being an addict because they came in with pain, But they know when you have real pain and you can stop that pain, the average person would not want more things that would boggle up their mind and things like that.
And if the clinician has a question about whether the person is using their pain medications properly and asking them for them properly, then you can get a psychological evaluation.
Oh, yes.
Now, we don't want to be offensive to our patients, and we don't want to make implications that they're doing something wrong.
Right,
But sometimes looking at a patient's perspective and what's going on in their life and things can give you good insight as to whether their requests for pain medication are reasonable or not. So if you're unable to make the judgment, you can continue the pain medication for a little while, but your deal with the patient is actually to have them have a psychological evaluation. Many doctors now are putting together pain management contracts with patients. So the contract sort of says what the patient has to do in order to maintain themselves on the pain management therapy they're getting, and what the doctor is offering to them. So the contract is an agreement that both sides can work on. And these pain contracts are becoming more and more
And it's really good too. Patients now can administer a certain kind of pain medication themselves when they're having the pain in hospitals. And I've seen this work tremendously. Patients were not addicts or anything like that, but when they had that very severe pain, and they could press the button to get a little more into their system. But since pain is coming to the end right now, and it's a pain in the neck that we have a certain amount of time, we'll have a last remark from you about pain or chronic pain.
Well, I guess chronic pain is a serious problem, and I think that what we need to think about in medicine is the phrase comfort care. Comfort care is a phrase that actually comes from the area of palliative care, taking care of somebody when they're about to die.
Oh, yes.
Let's make them comfortable.
Oh, yes.
But why can't we be making patients comfortable during their younger lives also?
That's right, of course.
So we need to inquire about things that are impacting on our patients' lives and making them uncomfortable, and pain is one of the biggest problems. So appropriate pain management is clearly the province of all of us who care about our patients.
Well, Dr. Sadowski, thank you so much.
Thank you.
You folks out there, who might have chronic pain, speak to your doctor. See if there's anything else that he can pass on to another physician who might be, controlling chronic pain. Sometimes the average physician doesn't get enough training in this field and so forth, and you will go on with your pain. But you deserve life. You deserve to be able to eat a good meal without pain. You deserve to sleep without pain or waking up with pain and things like this. And so it's up to you to make a positive movement, or your family to make a positive movement, if you just happen to be one of the relatives, or mother or dad, that can't function anymore because of chronic conditions, which affects the whole family. It's not just a one thing. So take care of your pain, and I hope I haven't been a pain in your neck. And I'll see you the next time.